Hi, I'm Dr. James Smithy. I'm a medical oncologist at Memorial Sloan Kettering Cancer Center focusing on melanoma and cellular therapy. I'm excited to talk to you about tumor-infiltrating lymphocyte, or TIL therapy today, and provide a broad overview that might be helpful as you consider this treatment option. So tumor-infiltrating lymphocyte, or TIL therapy, is a recently approved standard of care treatment for melanoma that's progressed on standard of care immune checkpoint inhibitors. So TIL therapy has been around for over 30 years, but only recently have we been able to administer this treatment across the country at a number of interdisciplinary treatment centers. So TIL works by first harvesting a melanoma tumor that's at least 1.5 centimeters, and this could be anywhere throughout the body. So we can harvest lymph nodes, we can harvest lung metastases or liver metastases. And then that sample is sent to a central laboratory, and the T cells, the cancer-fighting immune cells, are expanded over a period of 4 to 5 weeks. So this process basically augments your body's own immune response to the tumor, and those T cells replicate from several thousand cells perhaps to over billions of cells. And you need to have at least 7.5 billion cells in the final product to have a viable in-specification TIL treatment product. So that takes about 4 to 5 weeks for that to happen. The surgery and kind of the harvest process is usually determined by an interdisciplinary group of doctors, so your medical oncologist and your surgical oncologist, to really optimize the best chance at generating a specific TIL product that will be successful in treating your melanoma. During that period where you're waiting for the TIL product to be produced, patients can either be observed if they have relatively slow growing disease, or if things are growing more quickly, your team may recommend that some form of bridging therapy be used during this waiting period. And so this could either involve chemotherapy or targeted therapy or potentially other immune therapy to keep things under control while the TIL are being generated. So after about a month of production, we'll hear whether the T cell TIL product is ready for use. And at that time, patients will return to clinic. They'll undergo basic safety assessments at that time, including labs, including additional restaging imaging, and then start the process of the actual TIL treatment. So TIL treatment has 3 major parts. The first part is called lymphodepleting chemotherapy. So since the early 1990s, 2 chemotherapy drugs, fludarabine and cyclophosphamide, have been used prior to the infusion of TIL. And so fludarabine and cyclophosphamide work by lowering your native T cell population, specifically the lymphocytes, because our bone marrow in our bodies have a lot of other types of T cells that may not be melanoma specific. So prior data shows that by reducing the levels of these other T cells, there's more space and there's a more kind of favorable environment for the melanoma specific T cells to grow and fight the melanoma. So fludarabine cyclophosphamide can be given on a couple of different schedules. The most standard and kind of FDA approved version is a 5-day regimen with 2 days of cyclophosphamide, 5 days of fludarabine. And the main side effects from that to expect are fatigue, nausea, and reduced blood counts. So everyone will be checking your blood counts and your platelets very closely during that time. Patients do become susceptible for infections when the blood counts are very low, so just discuss that with your team as well. And then once chemotherapy is done, patients are admitted to the hospital and they have an infusion of tumor-infiltrating lymphocytes. And so this is your own cells that were in the tumor that have been expanded again to billions of cells. And that's just given as a standard blood transfusion essentially through a big IV. And so patients will need some form of larger bore catheter just for these cells to go in. And that's to prevent shearing of the cells and keep them in their functional state as they go into the body. Using small IVs like you would place in clinic may be too small and may damage the actual T cells. So the TIL infusion itself is usually quite uneventful. Some patients can have an allergic reaction to the preservatives. Patients get Benadryl sometimes before that just to prevent any allergic reactions. And you'll be treated in a cell therapy floor where they give these treatments all the time and are able to respond to infusion reactions. After that time, patients are then treated with high-dose IL-2, and this is really the 3rd phase of the TIL treatment. And this is the part that it's really important to be in the hospital for. So IL-2 used to be a standalone treatment for melanoma that was used quite frequently, and now we primarily use it after TIL. And IL-2 is really an immune-boosting cytokine that essentially acts like gasoline to help those T cells rev up and replicate and fight melanoma more effectively. So IL-2 can lead to replication and a more effective anti-tumor effect, but also it causes a lot of inflammation and potential side effects that we have to watch out closely for. So what does this look like? So this looks like as if your body were trying to fight a bad infection with no infection. So we can get fevers, you can see pretty severe shaking chills or rigors, that's something that's pretty common. You can see low blood pressure, and you can really see inflammation of almost any organ inside the body. So you can see elevation of liver tests, you can see fluid accumulate around the lungs, you can see the kidneys sometimes not be able to make enough urine. And so all of that is monitored very closely, again, in a cell therapy floor in an inpatient hospital. And at our institution, we check labs, twice a day, check vital signs every 4 hours, and measure each patient's urine output. If there's too much inflammation, sometimes patients can have low blood pressures and need to transfer even sometimes to the ICU. But what we know now is that you do not have to keep pushing patients with IL-2 if they are getting too sick from it. And we have pretty good data that stopping IL-2 early when side effects reach a certain level does not compromise the likelihood of responding to TIL. And so we have very strict guidelines at our institution of when it's safe to give another dose of IL-2 and when to pause. And most patients actually stop their course of IL-2 early and do not complete the full recommended 6 doses, which is how the FDA approval was written. Again, the maximum amount of IL-2 that a patient can get is 2 doses a day for 3 days. That's the maximum. But many patients stop earlier than that due to side effects. This is a pretty intensive process, and it definitely puts some, strain on your heart and lungs. So it's really important to get that testing, with your doctors before considering this, making sure your cardiac and pulmonary function are safe to go through this. But I think as long as you're at an experienced treatment center where it's very clear when to give and when to stop additional IL-2, this can be done safely in many patients with advanced melanoma. So once that's all complete, patients basically need to recover from the IL-2 and from the chemotherapy and then can be discharged home at that time. Usually in our hospital, it's about 7 to 10 days from the time of cell infusion that patients can go home. And there can be a couple of things that can keep patients in the hospital longer. So what do those look like? That could be if the blood counts stay low from the chemotherapy and do not recover as expected. There is a risk that some people may have what we call prolonged cytopenias or prolonged low blood counts. And in that setting, patients may get additional growth factors or additional transfusions, and the team will decide, when it's safe to transition that process from the hospital to the outpatient clinic, often with close follow-up. The other thing that can happen is during all that inflammation, there can be the accumulation of extra fluid. So sometimes patients need additional medications to help them, urinate off that fluid and get back to their normal weight. So that's a rarer side effect, but can happen in some people. A third thing that can happen is if patients are having fevers during their treatment, especially while they have low blood counts, they may, be started on antibiotics and have a potential risk for infection. So the team inpatient will want to make sure that the patient has, finished any important courses of antibiotics or any, workup that's still pending, like blood cultures, has resulted before the patient's safe to leave the hospital and go home. After leaving the hospital, patients are followed quite closely for up to 30 days after that infusion. At our center, we require that patients have a caregiver with them during that time, just for emergencies. We don't expect that they'll need a lot of assistance or care, but it's good to have, 2 people around in case there's an emergency to, call the center, bring the patient back to the emergency room if needed. We've seen in our experience the rates of coming back to the hospital after TIL are quite low. Most of the side effects that happen with TIL happen in the hospital, and patients generally see a slow and steady improvement in their side effect profile and their feeling those following weeks after they're discharged. At the day 30 mark, that's when we do our overall safety assessment and we see if it's okay to back off a little bit on some of that close monitoring. So I'll meet with my patients at day 30 and we'll determine, has the recovery gone as expected? Is it safe, especially if the patient came from far away, to go back home, to a neighboring, city or state? And do they need someone with them anymore? Are they okay to, kind of be a little bit more independent at that time? During that whole first 30 days, we are not focusing on, how well did the TIL work. We're just focusing on safety and side effects, making sure the patient is recovering and getting back to their normal, day-to-day activities. At the 6-week mark, so about 42 days after cell infusion, that's when we take our first look at whether the TIL have had the desired effect we were hoping for. So in the phase 2 study that led to accelerated approval, we saw that about 1 in 3 patients had significant tumor shrinkage, either at this first time point at week 6 or even later at week 12. And so this week 6 scan, will repeat body imaging. If there's any brain involvement, we'd repeat a brain scan as well and see, are the tumors growing? Are they shrinking? What's this early, look at how the TIL has worked? At that point, if things are going well and things are shrinking, the nice thing about TIL is that we do not need to use future treatment at that time. We can just continue to let the patient recover and have them come back in 6 weeks for their second set of scans. And so that, for me, is really the revolutionary, exciting part of TIL therapy or cell therapy in general, is that this really is a one-and-done treatment. So that if the TIL is working and we see tumor response, we are not obligated to give ongoing treatments with additional risk of toxicity, and patients can go about their normal lives that is, without the risk of frequent visits or new side effects. So that's been really exciting for me. And when we have patients who are responding and are responding for months and potentially even years after TIL, that's a really big game changer, especially for patients who have had a lot of side effects on prior treatments or other therapies. And so, what does the outlook look like for these patients, and what do long-term outcomes look like? As I mentioned earlier, about 1 in 3 patients has significant tumor shrinkage, and we know that about half of those responses are quite durable and can last for over a year. And now we have data, from the registrational phase 2 accelerated approval trial that shows, even 5 years later, there's a subset of patients who are still responding. So that's really exciting to me. And I think, it's hard to use the word, functional cure or remission, but some of those patients are living their lives for years after TIL treatment with no real, evidence or, effect of melanoma on their lives. So that's what we're shooting for. And we're looking, as we do further research on TIL, to increase the fraction of patients that meet that parameter, because that's what we really hope for in all patients. There are some, key factors when we think about, whether a patient is a good candidate for TIL therapy. One thing that's critical is just making sure they have good cardiac and pulmonary function and they can safely get through those IL-2 doses, which can put a strain on the lungs and the heart. Other things are just to think about, where would the harvest take place? Is there a good tumor that's 1.5 centimeters that can be harvested? So we'll meet for every patient that's considering TIL with an interdisciplinary team of surgeons and oncologists, and we look through their imaging and we say, is this a favorable site for tumor resection? Do we maybe need to use 2 tumors and combine them? That's something that can be done as a backup as well. And then what does the safety look like, for that surgery? What does the recovery process look like? So that's another big piece to deciding who's, a good TIL candidate. And the third thing is really the pace of disease growth and how symptomatic a patient is from their disease. As I mentioned before, it takes a few weeks to, set up a surgery date to get a harvest set up, and then it's another 5 weeks to wait for the TIL to be manufactured. So if someone has, very fast-growing disease and you're worried that they may be symptomatic or get too sick during that waiting period, you might think about other treatments other than TIL for that patient. However, especially if there's an effective bridging therapy option, most patients, with refractory melanoma could be considered, for this approach. And then the third and last bucket of things to think about is just what that, social support looks like. How does this fit into the patient's life? The patient has to be, kind of ready and willing to put a lot of their lives on hold for about a month as they go through this TIL process. And then do they have the family or friends that can help them and help them get back and forth to appointments, especially in the post-TIL recovery period? That's something that's also really important. We're trying to do additional work, to understand other factors that may make patients safer or, better candidates for TIL therapy, and a lot of work to do in this space as well as we try to understand the risks in different patient populations. I think one thing to note is just, should patients with brain involvement ever be treated with TIL? This is an emerging area and something that we're very interested here at our institution. In the trial that led to the accelerated approval, patients with brain metastases were allowed as long as they had been treated with either radiation or surgery beforehand. So that's, I would say, the standard approach. And there are emerging, trial data that it might be safe to consider this in patients with small asymptomatic brain metastases without treatment. But that's still an investigational approach and not a standard of care at this time. But lots of, exciting work in that field. And I think we have, a large population of patients that have brain involvement. We want to make sure that they can also, benefit from TIL therapy. Okay, and then I think something that could come up is what questions should a patient ask their provider or doctor as they're thinking about TIL. I think one is where does this fit into their other treatment options? Like, are there other trials to consider? Are there other treatment options? I think where and when you're doing this is really important. We do have data from some of the long-term follow-up from the accelerated approval trial, the C11401 trial, that patients with a lower disease burden and patients with less prior therapy actually have a higher chance of being long-term responders to TIL. So really our approach in our practice is as soon as a patient has been shown that their disease is not sensitive to our standard of care checkpoint blockades, we start thinking about TIL. And like, if it's something the patient would consider doing, we'd rather do it sooner rather than waiting for 3 or 4 additional lines of treatment. So that's one important discussion to have, and just timing with the provider. The other thing is having a realistic conversation of how safe is it to wait, for 3 weeks for surgery and then another 5 weeks for treatment, and what is the likelihood of successfully getting to TIL infusion? Because there are patients who are potentially too sick or symptomatic to wait that long, and it's a hard conversation. But I think really having that frank discussion is important up front with your oncologist. Getting into the details of surgery, which tumor will be harvested, are there features of it that look favorable or unfavorable? Really important to discuss both with your medical oncologist and your surgeon. And then, how does the hospital handle their, IL-2 administration? We mentioned some of our guidelines that we use at our institution. Are there protocols, to hold or stop doses? And, how frequently are patients, completing the full course for stopping early? I think that's important to think about and know as well. So I think those are all good questions. Everyone has different disease characteristics and subtypes, and there are definitely specific things that your oncologist might bring up around TIL, but for every patient, I think those are reasonable things to consider. And so I think those are the main things I wanted to cover, in today's video. If you have other questions, always feel free to reach out to the Melanoma Research Foundation, or you can contact us directly. So thanks so much.